طيب يعني قبل هيك حكينا عن التربيه الصبيه لقدام هون. قبل حكينا عن alkylating agents، قلنا عن variable antimetabolites، قلنا الفوليتس are antagonized، قلنا كمان pyrimidines are antagonized، وقلنا المثال الاول عليها هم الفلوروبيرميدينز. هلا المثال الثاني هو السايتيدين انالوجز. هلا في عندنا a couple of those. في عندنا اول واحد اللي هو السايترابين اللي قلنا عنه. Now cytarabine is a cytosine linked مع sugar اسمه arabinose, so that's why they call it cytosine arabinoside. But in protocols mostly you will find they mention the drug as trade name or abbreviation, so that they either mention aracine or one of the first trade names اللي هو cytosine. So the mechanism of action انه بيصير له uptake by special transporter اسمها ENT1, and this ENT1 has high expression in some types of cancers like leukemias بالاطفال، خصوصا اذا كان في mutations معينه زي translocation 411 which mediates a translocation اسمه بسموه MLL or mixed lineage leukemia, or translocation 821, inversion 16, translocation 916 or deletion 16. So all of those are mutations with high expression or uptake of the drug. And in addition to KRAS mutations. So all of those mutations are associated with increased intracellular concentrations of the drug. So those cancers with those mutations are highly sensitive to cytarabine or aracine. The drug is monophosphorylated by deoxycytidine kinase, then di and triphosphorylated, and then it incorporates into DNA or antagonizes DNA or RNA synthesis. Few mechanisms of resistance which are summarized as reduced activation or increased breakdown. Increased breakdown is mediated through cytidine deaminase, which is a common degrader of all cytidines or all, let's say, cytidine analogs, and deamination of deoxycytidine monophosphate also. This leads to the increased breakdown of the drug. في عندنا also activation or the first phosphorylation اللي قلنا عنها انه cytidine بيصير له monophosphorylation, di and triphosphorilation. The first phosphorylation is mainly mediated by an enzyme اسمه deoxycytidine kinase. So this is the cancer cells has low activity or express low activity or low levels of that, بصير بقلل activation of the compound. مشكلة الاورال administration of cytarabine انه cytidine deaminase is highly expressed in the GI mucosa, so you cannot give it orally. So it's given IV. IV also have half-life, so you have to give it IV infusion and over a long period of time. Also, طبعا the drug also aims to target, let's say, يعني في عندنا استخداماته systemic. So we give it either systematically, high dose aracine, to mediate and over long days of infusion to mediate its effect, or we could also give it intrathecally to clear the brain sites or CSF from cancer cells. Well, advantage here إنه liposomal formulation or administration there is advantageous. ليش؟ لأنه cytidine deaminase اللي هو بيعمل breakdown is found in low levels in plasma. In CSF. في liposomal formulation لكل الدrugs or like في attempt to improve features of drugs by modifications. زي ما احنا بنحكي انه في liposomal formulations للسايترابين، في liposomal formulations ل a couple of other drugs زي الدوكسورubicin or daunorubicin كمان. So liposomal formulation acts as a depot when injected into the CSF and is released slowly from there. It's used for multiple types of cancers, leukemia, childhood leukemia. في عندنا AML, it's acute myelocytic leukemia. في عندنا variant من acute myelocytic leukemia اسمه acute promyelocytic leukemia, APL. وعندنا also rapidly proliferating lymphomas. The old name for them was high-grade lymphomas, but nowadays بيسموها aggressive lymphomas. تكاثرهم سريع. They always use a high-dose approach. So high-dose approach has more like side effects, خصوصاً neurotoxicity. So adverse effects are many. One of them اللي هو myelosuppression. Also we have GI side effects on the antimetabolites. They share this like side effect. And we have also pulmonary toxicity. والأشهر neurotoxicity. So neurotoxicity could happen if you give it intrathecally, so it will have direct damage على tissues there, or you have toxicity على cerebrum or cerebellum. Okay, so cerebellar toxicity includes ataxia and slurred speech, while cerebral toxicity includes seizures, dementia, and coma. This happens more when the drug tends to accumulate, elderly and poor renal function. Another drug of the Citadine analogs is acetylcytidine. There are two drugs, in fact, similar to each other, acetylcytidine and Citadeline. Acetylcytidine, in fact, it is triphosphorylated and incorporates into DNA. And then it binds and inactivates an enzyme called DNA methyltransferase. All the DNA methylation is a process to regulate expression of certain gene fragments. So DNA methylation obviously targets certain areas with DNA اللي هي مناطق فيها repeated CPGs or CGs والبيناتهم phosphate nitrogen bases في phosphate links them. So sometimes they call them CG islands اللي هو cytidine and guanine. If they are repeated more than 11 times يسموهم CG islands and they are mostly phosphorylated, methylated. So if you bind DNA methyltransferase via as a cytidine, you inhibit its activity. And here you have something called hypomethylation of DNA. Hypomethylation is expected to enhance the expression of genes that prevent cancer, like tumor suppressor genes, or shift the cells to differentiation. That's why acetylcytidine in particular is used in a condition before transformation to full malignancy. يعني always leukemias في عندنا بيكون normal cells that before they transform to leukemic cells they undergo a transitional state اسمها dysplasia. Okay, والcancer is metaplasia or like neoplasia or neoplasia sometimes they call it. So before neoplasia في عندنا dysplasia. And myelodysplastic syndrome is that transitional state. Sometimes we could detect MDS. So if you detect MDS, you could have the option to shift back cells to normal via the administration of acetylcytidine or Citadeline. Those drugs, they might cause myelosuppression, GI symptoms, and in very high doses, it could cause also severe nausea and vomiting. Gemcitabine is another cytidine analog, but with differences. في عندنا many mechanisms of uptake of the drug. So they say إنه it reaches 20 times the serum levels of Citadeline compared طبعا to Citadeline, and we have differences in mechanisms of action. So the طبعا it's a difluorinated analog of cytidine. Okay, so this drug undergoes, as you can see, monophosphorylation by deoxycytidine kinase to the mono, di, and tri. So the di inhibits ribonucleic reductase enzyme, and also it inhibits, so here depletes deoxyribonucleotide pools, or formation of DNA. And the triphosphorylated, in fact, it inhibits DNA polymerase. In addition to that, it could be incorporated into DNA, and the repair of that damage, I mean, abnormal nitrogen base is added, so the cells would attempt repair, but repair would not be possible, and then the cell would undergo apoptosis. So, like, this is like how does it work? Gemcitabine, as we mentioned, it is deactivated by deaminase, or as it is obvious from the figure, it is deactivated by deaminase. It is given through IV infusion because of low half-life. It is used for multiple types of malignancies, but also if you combine it with radiation, you will get more damage. So it is advised not to be used with radiotherapy. The drug has multiple side effects like myelosuppression, non-hematological toxicities, which include flu-like syndrome, infiltration of leukocytes to many sites, especially the brain, which is called posterior leukoencephalopathy syndrome, which might cause some neurological toxicity or side effects. Elevation of AST and ALT, which is liver function tests or enzymes, which is mild and reversible. And sometimes it causes respiratory complications, which might be reversed by co-administration with corticosteroids. Long-term could cause hemolytic uremic syndrome, which necessitates discontinuation of the drug. Now, purine analogs are many. Most of them are purine analog, are adenine analogs, except for one, which is Nilabean, which is a guanine analog. Okay, so purine analogs, they include first of all 6 thiopurines, which are 6-mercaptopurine and 6-thioguanine. So in immunological conditions, we use a prodrug to 6-mercaptopurine, which is azathioprine. It was once like one of the drugs that are used for organ transplantation, but nowadays they are replaced by other drugs. So azathioprine is replaced by proliferation inhibitors like Silsept or Myfortic. راح نحكي عنه إذا حكينا عن organ transplantation. So 6-mercaptopurine would be metabolized by an enzyme called xanthine oxidase. And xanthine oxidase is known to dispose of other agents, like if you have nitrogen bases in the body, so the body gets rid of them. Now, pyrimidines, the body, in fact, it could use them like for, it could break them down completely. But for purine, there is a problem. They cannot be like broken down. So the body, in fact, metabolizes them to uric acid, and uric acid is expelled from the body. So uric acid in high levels could precipitate either in the joints, causing gout, or it could precipitate in the kidney, causing gouty nephritis. So this could create a problem, in fact. So there are many pathways, enzymes here. We have hypoxanthine guanine phosphoribosyltransferase, transferase, which either activates or deactivates compounds, or mostly activates, sorry. And we have xanthine oxidase, and we have another enzyme called TPMT, which is thiopurine acetyltransferase. But here, like, we have many intermediates in the activation of the drugs. TIMP, which is thioinosine monophosphate. Thioinosine monophosphate is thought to be a poor substrate for guanylyl kinase, so it is an inhibitor here to that enzyme. Oh, sorry. It inhibits for a conversion of inosine monophosphate to adenines and guanines. And we have also thioguanine nucleotides, which form eventually, and those are incorporated into DNA and RNA synthesis, and they cause like strand break or mispairing, which would be like difficult to repair, and then the cell dies. 6-thioguanine also is activated through an enzyme called hypoxanthine guanine phosphoribosyltransferase, or it is deactivated by TPMT, which which is thiopurine as methyltransferase. Now, what is important about TPMT? You know, it is reported in the population that there are some people with low metabolizing activity of TPMT, in a way that إذا المريض كان عنده homozygous، تخيلوا homozygous يعني إنه الجين is inherited from mom and dad. If you have a homozygous low activity TPMT enzyme, this means that you have to give 10% of the dose that you usually give to people. معناته if you are giving 100 milligrams of the drug with low TPMT activity, you have to give only 10 milligrams. Now, assuming that you didn't perform the TPMT activity or polymorphism, and then you gave a full dose to the patient, this means that you have caused severe deal of toxicity. أعطت 10 أضعاف الجرعة recommended to that patient. So it is one of the, in fact, one of the early recommendations for like genotyping or genetic testing in cancer patients is TPMT activity when you are about to give 6 mercaptopurine or 6 thioguanines or 6 thiopurines in general. Also, we have seen a xanthine oxidase involved in metabolism of 6 thioguanine. So 6 thioguanine, in fact, or 6 mercaptopurine, in fact, could be subjected to accumulation if you give a xanthine oxidase inhibitor. في عندنا دواء اسمه allopurinol. Now, allopurinol, gout, it is given in gout. But in fact, when cancer cells break down, they release their contents. One of them are purines. طبعا في many contents of a cell that are released and of concern: calcium, phosphate, potassium. Okay, so all of those would have been released inside the body, and the body is like should deal with them, and the body can't deal with them, so بصير عندنا electrolyte disturbances. One of them also conversion of purine to uric acid, which are eliminated in the kidney, which causes kidney or gouty nephritis. So allopurinol is used to prevent that complication. That complication, in fact, اللي هو تكسير خلايا السرطان, اسمها tumor lysis syndrome. And the tumor lysis syndrome, you have to prevent it. You could prevent it using allopurinol, but you also could treat it. يعني إنه في عندنا many complications حكينا electrolyte disturbances. And also uric acid accumulation could be prevented or treated. Sometimes you could predict the incidence of tumor lysis syndrome. خصوصا مثلا على سبيل المثال, high tumor load or high tumor burden is associated with TLS. And also induction phase of leukemia is associated with TLS. So you have to like predict those and try to prevent them or treat them. Side effects are many for 6MP, but it is mainly used for maintenance phase, قلنا هاي phase في العلاج اللوكيميا, to prevent its relapse. So قلنا إنه maintenance is 2 years for females and 3 years in males. Male gender is a high risk for, in fact, relapse of the disease, and maintenance therapy should extend to 3 years لللوكيميا. Adverse effects include myelosuppression, خصوصا إذا كان في عندنا low enzyme activity لل TPMT, nausea and vomiting, anorexia, stomatitis, jaundice. Some of them are rare and some of them are common. Also, there is the risk of opportunistic infection. So you have to see if you need to prescribe like antimicrobial agents with those infections. 6MP is teratogenic, cannot be used during the first trimester of pregnancy, and also it could cause secondary malignancies like AML, خصوصا إذا استخدمته for a long period of time, especially with a chronic disease like Crohn's disease. Fluidurabine is found in the phosphate form, and Fluidurabine and Chladdribene and Pentustatin, those are 3. They are highly associated with suppression of T helper cells or CD4 plus cells. So they tend to cause opportunistic infections more than others. So Fluidurabine is it's a 9-fluorinated analog of an antiviral agent اسمه Fluidurabine. So the drug, first of all, undergoes removal of the phosphate and then triphosphorylation to become Fluidurabine triphosphate, and this will be incorporated into DNA or RNA synthesis, and it will impair DNA and RNA synthesis. Now, زي ما قلنا, it has an immunosuppressive function through mediated through inhibition of CD4 plus cells, which are helper T cells, but also it suppresses, يعني احنا بنعرف helper cell بتساعد النظام المناعي, but also it suppresses T regulatory cells, and T regulatory cells are suppressors. So if you suppress a suppressor, you activate immune responses. So sometimes there are some immunostimulant effect, paradoxical ones. في عندنا mechanisms of resistance زي ما قلنا, inhibition of breakdown or inhibition of activation, or stimulation of breakdown or inhibition of activation. Here also we have increased efflux or decreased activation or increase of one of the target اللي هو ribonucleic reductase. The drug is given orally or IV, and dose reduction should be performed with poor renal function. It is used for chronic cancers like chronic leukemias or chronic lymphomas, or زي ما قلنا low-grade lymphomas. This is the old name. Nowadays they are called indolent lymphomas or slowly growing lymphomas. It is myelosuppressive. It causes minor or mild nausea and vomiting. Causes some complications, but only the most specific is its effect on CD4 plus cells or helper T cells. Could cause autoimmune events, paradoxically, through effect on T regulatory cells, and it could cause effects selectively على RBCs, either hemolytic anemia or pure red cell aplasia. ايش هذول بيطلعوا صوت؟ والله بيطلعوا برا. سكروا الباب براكم, ها؟ في عندنا also tumor breakdown, which we mentioned as tumor lysis syndrome, could happen, and this is specifically for patients who are being treated for the first time if they have CLN. It causes some neurotoxicities also, mild dysplasia, which could progress to acute leukemias, and it could cause pneumonitis, which could be prevented by co-administration of corticosteroids. Chladdribene is another agent, and it's also similar to Fluidurabine in its toxicity on CD4 plus cells, so opportunistic infections are predicted with that. It undergoes mono and di and triphosphorylations through an enzyme called deoxycytidine kinase, which is like specific for pyrimidines, but also it phosphorylates purines. And mediates death of cells in similar manner. Resistance is mediated through overexpression of a target, which is RNR, or downregulation of activating enzyme, or pumping out of outside of the cell. But here, like Chladdribene, they know that certain transporters called ABCs or ATP binding cassette transporters are involved. It is used for like low-grade lymphomas or indolent lymphomas, some other forms of cancers. CTCLs are cutaneous T-cell lymphomas. Adverse effects include myelosuppression, opportunistic infections, as we mentioned, and like other ones, like tumor lysis syndrome. Clofazimine is a new congener it's used specifically for ALL if previous therapies fail, or AML and also in mild dysplasia. This drug is resistant to some other mechanisms of resistance, like overexpression of glycosylase. It's an enzyme that breaks down or repairs DNA if like faulty nitrogen bases are added. So this one is resistant to that repair enzyme. Now its modification, fluorination and addition of arabinose sugar to it, in fact enhances its entry inside the cells and also stability inside the cell, so reduces its deactivation. Side effects include myelosuppression. Also في عندنا syndrome of capillary leak and cytokine release, which would cause some complications. If this happens, you have to immediately discontinue the drug. And elevation of liver enzymes, nausea and vomiting and diarrhea, and hypokalemia and hypophosphatemia. Nilabean is also a new drug, which is a guanine analog, as we have mentioned. So this guanine analog would undergo activation through deoxycytidine kinase, and in addition to that, deoxyguanine kinase, and undergoes triphosphorylation and then incorporation into DNA and mediates its effects. It is specific for some high-risk leukemia, for T-cell leukemia. I think كمان الفلوربارابين is also that, like that, but Nilabean is specifically mentioned as a T-cell ALL specific. Adverse effects are myelosuppression, liver function abnormalities, and also neurotoxicity, which includes seizure, delirium, somnolence, peripheral neuropathy, and some form of peripheral neuropathy called Guillain-Barré syndrome. Now, Guillain-Barré syndrome is a side effect which you would encounter with older forms of vaccinations. But the newer forms of vaccination, they don't have the Guillain-Barré syndrome or this neurotoxicity. Pentustatin, as we mentioned, it is also a bone marrow suppressive agent, but in addition to that, it causes renal toxicity. It inhibits adenosine deaminase enzyme, which deactivates like those adenine analogs. Also, it has multiple mechanisms of action, like triphosphorylation, which is incorporated in the DNA and the RNA synthesis. Deoxyadenosine metabolite inactivates S-adenosyl homocysteine hydrolase and leads to accumulation of S-adenosyl, which is toxic to lymphocytes. So, like Pentustatin has multiple mechanisms of action. Adverse effects include myelosuppression, GI symptoms, skin rash, abnormal liver function tests, also depletion of T cells, and increased of opportunistic infections, as we have mentioned, especially if you combine it with Fluidurabine. But also combination with Fluidurabine causes severe and fatal pulmonary toxicities. Now, people who have adenosine deaminase genetic mutations or deficiency are more susceptible to the side effects of Pentustatin, in fact. Now, we mentioned the antimetabolites, we mentioned alkylating agents. Now we will talk about the naturally occurring agents. The first group is microtubule damaging agents. There are many ones. The major two are zinc alkaloids and taxanes. Now, zinc alkaloids, they include 4 drugs, vinblastine and vincristine, which are historically the oldest ones. يمكن ما حكيتها بالمحاضرة اللي قبل, but for vincristine, الاسم التجاري بتاع الفينكرستين is oncovine, and it's sometimes like used in protocols like as an O. Okay. So those are historically the oldest agents. They have been used for leukemias, lymphomas, testicular cancers. فعندنا another drug called Phenurabine. This is 3. Phenurabine is used in lung and breast cancer. فعندنا Vinaldicine, and it is used for breast cancer. So like it's not mentioned in the textbook. So in general, zinc alkaloids, they impair disrupt microtubules like structure. And microtubules, they are not only involved in mitosis. So as you know, like when cells divide, they divide their genetic material. And then 2 centrosomes will go to the poles of a cell, and then they extend microtubules to grab a copy of the genetic material, and they start depolymerizing and polymerization, and this will pull DNA copies to the poles أو أقطاب الخلية. So microtubules formation, the first step of like mitosis or انقسام الخلايا, is impaired by zinc alkaloids. Now, microtubules are not only involved with that, but also they are involved in movement of immune cells, like or the function of phagocytosis. But also, يمكن قلناها قبل هيك, neuronal cells, they have cell body and then axons, and then we have synapses. Okay, so in fact, neurotransmitters, they are synthesized in the cell body, and they are transported along the axonal routes. And axonal routes, in fact, they are vesicles transported using some movement proteins called kinesins and dyneins, forth and back from the synapses, and also they move on tracks, and the tracks are microtubules. So zinc alkaloids, which disrupt microtubules, which are neuronal tracks, they cause neurotoxicity. But neurotoxicity or side effects are variable between the zinc alkaloids. But they share commonly the mechanisms of resistance. So one mechanism of resistance is active efflux through P-glycoproteins, or active efflux through multi-drug resistant proteins or breast cancer resistance protein, and mutations in the binding site of tubulin, or production of subtypes of tubulin or beta tubulin, which is the target of binding of zinc alkaloids, which has this affinity to the zinc alkaloids. Now, adverse effects, as we have mentioned, vincristine has more neurotoxicity compared to vinblastine, while vinblastine has more myelosuppressive effect compared to vincristine. Phenurabine has moderate profile of toxicity. Overall, the drugs, they are eliminated by the liver. And if you have a bilirubin level more than 33 grams per deciliter, 3 milligrams per deciliter, you have to reduce the dose at least by 50% of the original dose. Vinblastine, when administered subcutaneously, it will leak from the blood vessel or from the injection site, and it will cause damage to the site of administration. So it is always recommended to infuse it in a fast blood vessel, like a vein or or a central line, like for example. So, like for drugs, extravasation is a serious, for cancer chemotherapy, a serious adverse. So for zinc alkaloids, you have to use warm compresses, تحطها على موقع الانجكشن, and to inject an enzyme called hyaluronidase. Hyaluronidase is an enzyme that inhibits the destruction of tissues by tissue damaging enzymes, MMPs. بيستخدموا أكثر شيء لعضة الأفعى, the snake bite. So here the recommendations for zinc alkaloids induced extravasation, مثلا, for example, is to apply immediately warm compresses for 30 to 60 minutes, then alternate off on every 15 minutes for 1 day. And then to inject 150 units of hyaluronic days at the site. هلا في drugs في لهم specific extravasation antidotes. Like for example anthracyclines, they use دواء اسمه dextrazoxane بالعادة. مش عارف انه موجود مكتوب عليه ولا لا. هاي dextrazoxane like في له doses مثلا معينة. Once daily for 3 days. First dose should be given within first 6 hours. Day 1 1000 milligram per meter square IV. Day 2 1000 milligram per meter square IV. Day 3 500 milligrams per meter square IV. And also some procedures, different procedures. Like for example with anthracyclines, for vinculioids, when you give warm compresses, you enhance the clearance of the drug from the site. But for anthracyclines, they recommend انك تستخدم cold compresses to reduce the damage at the site of administration. It seems like with practice, they found out that cold compresses are better than warm compresses in anthracyclines, while it's warm compresses that we use with vinculioids. Also, it causes myelosuppression, زي ما قلنا. It's the specific side effect, and the nadir or the peak of reduction of white blood cells happens at day 7 to day 10. Side effects include myelosuppression. It has mild neurological manifestations, GI disturbances like nausea, vomiting, anorexia, and diarrhea. It causes SIADH. It also causes loss of hair, stomatitis, and dermatitis, and it causes extravasation. Vincristine has, زي ما قلنا, a little bit different toxicities, like neurotoxicities. It has multiple manifestations. Mainly, it could cause the GI paralytic ileus, it causes, or gastroparesis, like slowing down of gastric movement. It could cause constipation due to that. That's why for vincristine in particular, they limit, مش عارف هاي من الكتاب موجودة. They don't, the side effects peak at 2 milligrams per meter square or more. This is a textbook. But from clinical practice, I know, if you look at the doses مثلا of vincristine بالبروتوكول مثلا بيكون 0.7 to 1.4 milligrams per meter square. زي ما قلنا احنا بنحسب البادي سيرفيس اريا and then multiply that with the dose بتاعت المريض بيطلع لنا الدوز اللي لازم تعطيها للفينكريستين. But for vincristine in particular, if you calculate the dose and it was more than 2, you peak the dose at 2. يعني لو حسبناها طلع 2.4, you don't get more than 2. The cap, you cap the dose at 2 milligrams for vincristine in particular. Also, vincristine is used, or vincristine is used, let's say, for leukemia. Or for leukemia, زي ما احنا ذكرنا في عندنا Citadeline and Microtubules, and those are given intrathecally. And coincidentally, they are given concomitantly with vincristine to reduce. دائما احنا in practice we try to reduce the injection times of drugs. But you have to know that if you gave vincristine and methotrexate intrathecally, you will kill the patient. يعني this is like a common mistake in oncology, like to give vincristine intrathecally together with methotrexate. You have to know that vincristine is fatal if given intrathecally because it is devastating and often fatal with irreversible coma and seizures. So you should label it, do not give intrathecally. Okay? For effect on myelosuppression, it causes modest leukopenia and rarely thrombocytopenia, anemia, or SIADH. So it's unlike vincristine. We have Ribonucleic. It's used for lung cancer, for breast cancer. I think for lung cancer they use it تأكد والله بس. So they use it for non-small cell lung cancer. Side effects are modest يعني زي ما قلنا, include granuliocytopenia, modest thrombocytopenia, less neurotoxicity compared to vincristine, allergic reactions, elevation of liver enzymes, elevation of plasma bilirubin. زي ما قلنا, if the bilirubin levels are more than 3 grams milligrams per deciliter, you have to reduce the dose at least 50%. So if it was higher, you have to reduce by 75%. هيك احنا خلصنا مقارنة بالشعب الثانية. اوكي؟ في عندكم اي سؤال؟ شكرا جزيلا. يعطيك العافية. الله يعطيك العافية يا رب.